YouTube Live as we continue this series over the summer to best practices to develop clinical judgment skills. And it's already the middle of August. We had a beautiful summer day here in Minnesota, in the northern suburbs of the Twin Cities where I live and here in my home office. But as we look at how the summer is going all too quickly, I'd love to know, how are you doing preparing for a new year? Are you anticipating it? Are you dreading it? Or are you saying, bring it on? I'm ready. I'd love to know how you're doing out there in the chat. So if you're out there tonight, please just give a shout out in the chat. Let me know what state you're from, where you're making a difference in nursing education. But just like to add this, if you'd like. What do you resolve to do differently with the upcoming new year? What are some of the goals or things that you would like to do differently to strengthen how you teach, to better prepare your students to develop the clinical judgment skills for both practice and licensure? And if you're checking this out for the first time, the goal of this live stream is really simple. It's my passion to support and serve the needs of nurse educators in the trenches, those that are doing their part to make a difference and develop that clinical judgment, improve that transition to practice. So again, our students transition to practice and are well prepared for NCLEX, including the upcoming next gen. If we haven't met, my name is Keith. I'm the founder of Keith RN, and it's really my passion to lead the vision or lead the vision to change how we teach nursing education, close the ongoing academic practice gap, and just empower educators with the tools and resources to bring about needed change that is very needed in nursing education, because we have numerous struggles that we're facing, including the ongoing academic practice gap, the upcoming next gen, the incivility that we experience at times from our students and even from our colleagues. But as we look at nursing education, why I'm so glad you're here is that, how do we change nursing education? How do we transform our profession and how it's taught? It's really one educator at a time. And every one of you who are listening to this, either live or recorded, are part of the needed change. And it's just my desire to just encourage you tonight and to make the most of this time that we have today. And so I just, again, want to thank you for taking time out of your busy schedule to spend this time, as we're going to be talking about in just a few minutes on really how we as educators can empower our students to notice problems, to develop, talk about the problem of failure to rescue, what it is. We're going to break it down. But more importantly, we're going to talk about the problem, absolutely. But then I'm going to show you a path to how we can strengthen our student learning so that they recognize problems before they develop into a needless complication. So it's a very important topic. It's a matter of life and death. So please stay with me. You're going to find this really helpful. And I just want to say thank you, Destiny, for coming on board tonight. I'm so glad you find them insightful. And Diane from Los Angeles, it's a blessing to have educators, usually from coast to coast. And here I am in the Midwest, in Minnesota, just again. But we're all in the same boat. We all are just basically wanting to just strengthen. And again, like every nurse educator, like the motto of home improvement, Lowe's home improvement stores, never stop improving. That's our mission. It's my passion as well. But I want to encourage you with just a little thought here before I dig into today's topic. And I'm going to call this little thought, do the hard and painful things. And, for me, this is a metaphor. It's a personal thing for me because I've gotten a little flabby since the pandemic and I'm not in the best of shape. But I'm blessed to have a daughter who was a Beachbody coach. And if you know Beachbody, they have little 20, 30-minute intensive workouts. They have lifting, fitness, aerobic. Well, I'm doing kind of a weightlifting one. And I did the first 2 days this week doing just 10 and 20-pound barbells of some bicep curls and other lifts. And I'll tell you, I could literally not lift a cup of coffee the next day. And I thought I had ruined myself. I thought I had torn muscles. Something was wrong. I called my daughter. You know what she said, Dad? I said, Dad, that's a good thing. Pain is good because it tells your body that you did it right. You get little micro tears in your muscle fibers when you lift correctly. Now, I can move my arm, so I'm not an invalid. But it was hard It was painful. And she said that pain is good because it means you're doing something right. And I want to kind of just maybe just make a leap here to every one of you as educators, that when you look at nursing education, it's an easy or a hard path, isn't it not? When you do active learning, when you bring about needed change, when you do what is needed for such a time as this, is it easy? Absolutely not. You got a target on your back sometimes by your students. They don't want active learning. They resist it. Your feedback is not always what you'd like it to be. That is painful. But yet, let me encourage you that doing what is needed, like getting in shape, it's going to cause pain. That's expected, and it's not a negative. I want to encourage you, like you do in a good workout, you fight through it and recognize that if you're on the hard path, if you're on the painful path at times, you're on the right path, because that's what's needed. And our bodies are kind of a metaphor for this reality. And even Jesus used the metaphor of the hard path that leads to life that is difficult. It's not easy. But yet, and I believe that path leads to transformation in nursing education, because what Dr. Benner is calling us to in educating nurses, a call to radical transformation, is doing the hard things, contextualizing our content, bringing active learning, bringing clinical to class. And again, our students won't always value it, but we must bring it on and endure the pain, knowing that we're doing the right thing. We're doing what's needed. And I want to encourage you all as educators to stay on that path and to stay the course. And I am there behind you. I've got your back. I'll do all that I can to serve your needs in nursing education. So again, thank you for joining me. And Lori, thank you for joining us from Pittsburgh. It's a blessing to have East Coast, West Coast. And I know there's many more out there who are a little bit bashful today. But you know what? If you want to just at least give me your name, your first name, and where you're coming from tonight, that's a blessing, because here I am talking to a microphone and a video camera in the Twin Cities. And it's just a blessing to know that there are people out there that are watching this. And I know there's many out there. There's dozens of you today. And thank you again. And yes, Diane, you are so right, because, I got really paranoid because I, as an ER nurse, have seen people in the, come into ER with acute renal failure because of acute workouts. And I said, I'm drinking lots of fluids, Diane. So you're thinking just like me, overthinking it as an ER nurse. And I think as nurses, that's a good thing. And so far, you know what? I've been voiding. That's as far as I'll go. I think I've got my renal function intact. So I'm thankful for that. Destiny, again, from North Carolina, Karen from Danville, Virginia, Patsy from Georgia, Chris, Douglas, I know who you are. Blessed to have you in Georgia, Pennsylvania. I see Lisa and Amanda and Mississippi. And Amanda, I'm coming to Mississippi October 7th to my alma mater, William Carey University in Hattiesburg, to do a full-day conference October 7th. I hope you can make it to that. I'm looking so forward to it. Love Mississippi. Love the accent. Love the weather. Love the hospitality. As well as Andrea from Missouri and Julia from beautiful Orange County, Southern Cal, and Dr. Coleman from Illinois. So, wow, we've got a lot of people here and all over. It's just a blessing. So thank you for joining me tonight. And, I just like to jump in and just talk about, when we talk about, problem recognition and clinical judgment, I think, like I talk about every time, and I think it's imperative, and I'm not going to stop kind of on this bandwagon, but it really is. We are in a crisis in competency right now, where we are struggling to develop the practice readiness of our students. And again, I'm not blaming educators for that. What I'm saying is that the statistics from Kavanaugh and Svita's study are showing that the decline in clinical judgment, which again impacts the decisions that our students are making, we're going from 23% of practice readiness in the most recent follow-up study that Kavanaugh and Sharpneck did in 2021 with the Cleveland Clinic, onboarding over 1,000 nurses, graduates, all who passed the NCLEX. Currently, less than 10% can do two things with a problem recognition scenario: recognize the problem and then know what to do to respond appropriately. So again, those clinical reasoning steps we've been talking about that we'll highlight briefly: noticing what's most important, interpret the meaning correctly, then responding appropriately. Those are the first 3 steps of Tanner's clinical judgment model that align with the nursing process. They also align with the NGN model. So the bottom line is that our students, my posit in some of the research that I'd love to do in the future with my PhD is to look at the need of using unfolding case studies that are low fidelity simulation to practice clinical judgment. And I think that, we need to remember that as educators, let's step back from all the content, all the information we need to do, what's in our curriculum, and let's step back and remember that the most important skill your students must possess is the clinical judgment to make the right decision. And I've been talking about some of the ways that we can develop that, the reasoning processes. And so these live on prior YouTube's lives on my YouTube channel, Think Like a Nurse. If you haven't subscribed, you can simply go to that channel, either subscriber or not. And prior YouTube lives that we've been talking about all summer, how to strengthen clinical judgment, are there, as well as even some shorter 5-minute videos and 3-minute videos I've done over the years. And so I just commend those to you. But again, as we look at failure to rescue, it really comes down to a failure to recognize or notice what is most. It's the first step of Tanner's framework, and it impacts patient outcomes. And I really want to encourage us as nurse educators, yes, are we worried about the next gen NCLEX? Absolutely. And we should be. We want them to be successful. But let's never lose sight that the reason we want to develop clinical judgment skills is to improve patient outcomes and to prevent needless death even as a result. And I'm just humbled that Dr. Phil Dickinson reached out to me earlier this spring to be the keynote presenter at this upcoming NCSBN Virtual Next Gen Conference here coming up next month, September 22nd, where I'll share build on the things I'm going to share even tonight. I have a little bit more time to go into some details I'll never be able to do during the Next Gen Conference. I just have too little time and too much important information to share. So it's a blessing to kind of just take my time a little bit longer. We're not going to go too long. We'll go no later than 9 o'clock, if not a little sooner. But again, I value your questions and those things that you'd like. And so Patty, it's a blessing to see you, one of my board members. Thank you for joining me tonight. And Diane, blessing to have you. And Elizabeth, thank you. Yes, it is a pleasure. It is really an honor. I didn't expect it. I thought Phil Dickinson was going to criticize me for some things I said on YouTube that I might have gone over the edge, but he said, you're on the right edge, Keith. And so to have the NCSBN basically state that, Keith, what you're sharing with educators we're behind it. It's not, and I just want you to know that just means a lot to me because, like I've shared in the past, I've had a pretty broken road in nursing education, not well received, and a lot of incivility that's really limited my ability to teach even in the academic setting. But God opened doors, and Keith RN has been going on for 10 years, and it's just a pleasure to serve your needs, to teach still, but to teach educators or empower them with some of these best practice strategies. So again, thank you for joining me. I would like to share, as I talk about problem recognition, there's one story that you all need to bring to your students, and that is Lewis Blackman. I'm going to be leading off this session tonight talking about his story, because this is a tragedy that as educators, we need to know this story. And this is a link that is on a patient safety website. And Lewis Blackman, I'm going to get into the story in just a moment and talk about the importance of problem recognition and how we as educators can bring about needed change. And what I'm going to be sharing from tonight is that I have a 3-volume set of clinical judgment texts that I just released this spring. In volume 3, basically deconstructs Tanner's framework and those steps of noticing, interpreting, responding, reflecting, problem recognition, and failure to rescue. And I'm going to kind of highlight chapter 8, which is titled How You as a Nurse Can Improve Patient Outcomes and Prevent Patient Death. And so this chapter was written for students, and this resource has been adopted by programs across the country already, which is just humbling. But I also want you to know that the information I'll share is relevant for every nurse educator. And one of the articles that I cite in this chapter 8 is called The 5 Rights of Clinical Reasoning. And this is a poster based on this article that was published 12 years ago by a nurse educator in Australia, Tracy Levitt-Jones, who's doing some innovative work with clinical reasoning. And we're going to talk about that in just about later on tonight. So I'm not going to go into the 5 rights, but I want you to access it. It's a 1-page poster that Tracy Levitt-Jones did in Australia at a conference for nurse educators. And I'll tell you, she's doing some incredible work. And that article is a must read for every educators. We have the rights of med administration. How many of you as educators know about the rights of clinical reasoning that lead to problem identification and recognition? You know, that's what she talks about in this article. So again, I commend that to you and what that looks like. But, you know, for tonight, let's go ahead and let's get into today's topic, which is the chapter in my book. I'm just going to share my screen and keep it really simple and what this looks like. And so this is chapter 8 of, and again, there's the title, and it was co-authored by Julie Seamers, a colleague that I met at a conference that I presented at, and actually to her department in Las Vegas, Nevada. And she did her dissertation on failure to rescue. So she co-authored this chapter with me, and I'm really excited to share it with you tonight. Just going to highlight it. But, you know, when we look at, nursing care, you know, one of the things that I opened the chapter with, the nurse holds the life of a patient in their hands. And, you know, our students forget that. We must remind them of that reality, because sometimes they come in thinking that nursing is all about them, their success, and what we need to do to meet their needs. But we need to help our students see that no, nursing's different. Nursing is about caring and serving the needs of others, and you need to be the best, not just good enough to pass the test, so that you don't harm your patients. It's all about the patient, and we hold literally their life in their hand. And I think it's really important that we give our students a metaphor. I love metaphors. They're great illustrations that illustrate life with truth. The one metaphor that I use in this chapter is lifeguard. The nurse is a lifeguard who's scanning the horizon of the beach, the ocean, the pool, looking for a struggling swimmer. But in the context of patient care, the nurse is a lifeguard looking, as they have their patients, their 3, 4, 5, 6, however many patients they have assigned. Every patient is their responsibility. They're looking for a potential problem, a complication that could develop, and what that looks like, and then identify that struggling patient early and literally rescue them. That's why I love the metaphor and love the term failure to rescue in nursing, because it really captures the essence of that lifeguard metaphor, that as nurses, that's what we do. But, you know, Lewis Blackman, I'm just going to read this to you, because what this story is something that we need to bring our stories to our students. You know, we have our own stories that we need to bring that are powerful illustrations of nursing practice, but we need to bring the tragedy as well as the successes. And Lewis Blackman is a tragedy, a needless adolescent, a needless death of an adolescent who died at the age of 15, needlessly, because of a culmination of many kind of things that did not go well, including the nurse who failed to recognize. But like other errors in practice, failure to rescue is complex, because it also involves things like short staffing, unsafe staffing, the inability of the nurse to have the time to do what is needed because of multiple demands. The inexperience of the nurse compress that and exaggerate that reality, as well as the culture of the setting. All of these things variables. So this is not blaming nurses, But it's also recognizing that nurses have the responsibility to own their practice, their excellence, and the application of knowledge to the bedside. Louis Blackman, here's his story. He was a 15-year-old who underwent elective surgery at the University of South Carolina for a congenital chest deformity. On his first postoperative day, his urine output was low. He was given ketorolac to treat his pain, a nonsteroidal anti-inflammatory drug that should be used with caution in post-op patients because of an increased risk of acute renal failure, internal bleeding, and perforated ulcers. He was in the hospital for 6 days and had a low-grade temperature. His feet, which were once warm to the touch, were now cool. The next day, despite receiving ketorolac for pain, Louis complained of worsening abdominal pain to his mother, stating, "It's the worst pain imaginable." Louis's mother reported this to the nurse, who dismissed the significance of this finding. The nurse did not collect additional assessment data to cluster, and instead the nurse assumed that his complaint was due to gas pain and encouraged him to be more active. Later in the shift, his mother was concerned and reported that Louis was getting weaker, but the nurse did not notice that finding as concerning, and the assumption was that this was gas pain, and the nurse insisted that Louis needed to ambulate in the halls despite receiving ketorolac that was not relieving his pain. Let's just pause for a minute, because as we look at Tanner's framework that we've been talking about all summer, as we talk about the noticing skills, what do you notice that is most important? Can you identify some red flags, even from your vantage point as a nurse that wasn't engaged in this scenario? You know, there were things already present. The fact that the pain was getting worse 6 days after surgery. You know, the next gen is going to ask this question: what findings are expected or unexpected? I love that question because it really fleshes out how a nurse needs to think in practice, which is this what I'm seeing? Is this expected or not? Because if it's not expected, it's a problem that's likely developing that I need to react to or respond to appropriately. And so again, I want you to see how, as we've talked about the different noticing questions we must ask our students, and we talked about that about 3 sessions ago, please go to that and look those up, because that is going to give you valuable information as an educator, how to effectively develop these problem recognition skills. So again, there's numerous things here that were unexpected. The increasing pain, that was the worst possible pain. And Louis was a healthy adolescent, didn't have any other comorbidities. So the story continues. The pain continued, but now his abdomen was firm and distended. His skin was pale and cool. His forehead was diaphoretic, and his heart rate increased to 126 a minute. His eyes were sunken, weaker. Abdominal pain was now constant. His mother continued to voice her concerns and requested the doctor evaluate her son. Well, the chief resident did evaluate Louis. Again, an inexperienced physician ordered a suppository for a possibly blocked intestine and did not incorrectly noted the heart rate as being in the 80s, when in fact it was 126 a minute. And the resident assured that the sweating that he was experiencing, the diaphoresis, which is fight or flight, was a side effect of his medicine, had no urine output for 12 hours. And again, let's just pause. As a nurse, if you were that nurse, what is unexpected? What are you concerned about? Why is that heart rate 126? You know, when we look at interpreting, you know, the next phase of, when you look at clinical reasoning, you know, Tanner's process begins with noticing what's most important, but then what's the interpretation? What does it mean? When that heart rate's 126, the nurse needs to apply their knowledge. And we talked about the importance of understanding essential content related to pathophysiology, like cardiac output equals stroke volume times heart rate. Why that must be understood by every nursing student is really simple. Louis Blackman, was having a compensatory response to a low cardiac output state. He was in some degree of shock, and unfortunately it was internal bleeding, unrecognized. But he was in shock, volume depleted, tachycardic. Why? That's where the nurse can apply their knowledge and be a superhero and save a life by responding early. Well, the problem unfortunately progressed, and he had no urine output for 24 hours. The nurse used a machine to maintain his blood pressure, to obtain the pressure, and no pressure was detected. Tried several times over the next 2 hours, didn't bother to do a manual. One of the things we must teach our students is that a non-invasive blood pressure machine has limitations. If you don't get a blood pressure when a patient is hypotensive and it just doesn't give you a reading, that's a red flag the first time. Maybe do it a second time, but then get a manual right away. Because in practice, I have noticed that same phenomenon. It will not record. If it's like in the 80s, systolically, it doesn't pick it up. So therefore, the nurse didn't recognize that finding. And again, heart rate increased in the 140s. Lewis states it's going black and arrested. And you know what they found out? He was bleeding internally. His stomach was full of blood, about 3 liters in his abdomen. Most of his blood in his body was in his gut. And again, he likely had a gastric perforated ulcer as a result of a side effect of ketorolac. And I think it's really important for us as nurse educators. There's a lot of stories that get attraction on the news that we sometimes hear about, but we need to remember that when we look at preventable patient deaths that include failure to rescue as nurses, as well as medical errors, med errors by doctors, physicians, pharmacists, according to Macri and Daniel, it's 250,000 deaths in the United States every year. Third leading cause of death, medical error. And again, we want to be part of the solution. And that's my passion. And I just want to encourage us as educators, how we can make a difference and why we need to develop the clinical judgment that is so foundational for practice. But I want to break down, failure to rescue in 3 different ways. We got to deconstruct it a little bit further to really understand how can we then strengthen our student learning of what's most important. One of the things that our students struggle with as a new nurse in practice, according to Janet Menegal and her research in 2018 with Kathy Lassiter on new nurses and transitioning to practice, priority setting and interprofessional communication, doing SBAR. And so anything that we can do as nurse educators to practice SBAR in the classroom, SBAR in simulation, SBAR in post-conference, we need to practice how a nurse communicates, not only giving a handoff report, but also giving a change of status report, because sometimes a new nurse it doesn't have that communication. We don't get, as students, they get very little to none communication to a provider. That's not their scope, but they don't get that experience. But we need to practice it. We need to simulate it as much as we can. But when we look at failure to rescue, it's 3 aspects: a failure to recognize the problem, recognize not just the problem, but really recognize the most concerning information. You're just getting some vital signs. You're getting this information. You don't notice it. You also have a failure to act. You don't recognize the urgency. You see, if you don't notice and you don't interpret it correctly, you'll say the world is fine. No problem here. But the patient is decompensating. And the third is a failure to communicate. That's why it's so important that if there's one thing I want you to just take away from this is recognize the importance of communication and practicing SBAR, problem recognition, and communicating a change of status to a physician. And if you want to be kind of, I wouldn't say mean, but realistic, be an antagonistic provider who doesn't like being woken up at 3 a.m, and you better have your A game and make it concise and real and to the point. Because again, our goal as educators is putting practice first, preparing our students for real world practice that will also translate to NCLEX success. And again, these strategies of priority setting are foundational as well to NCLEX success. So again, let's practice that. And that's why when we look at the first aspect, failure to rescue, the failure to recognize, that's why we need to really embed and embrace, practicing those noticing skills. What do you notice that's most important? What do you notice that's concerning? What do you notice that's expected or unexpected? Those are the ways that we unpackage noticing. And we ask these questions in clinical, in simulation, in debriefing, in case-based learning that we bring into our classroom. But we bring about those practical strategies and those ways of developing noticing skills. And another thing that we need to develop with our students that I highlighted here is pattern recognition. That's an interpreting skill. It's looking at how is clinical data related to each other. So for example, with Lewis Blackman, he's tachycardic. He is having worsening abdominal pain. His blood pressure is dropping. What does all this mean? Are these just abstract, or is there a relationship of the tachycardia, the worsening pain? That's where a thinking nurse can save a life when they cluster that data. That's why concept mapping is so powerful. It practices the interpreting skill of clustering or pattern recognition. Use it. I commend it as a best practice strategy to strengthen the interpreting skill, the second process of clinical reasoning. And then, the failure to act or escalate. Again, if you don't notice a problem, it's kind of like the house is on fire, but you don't know, you don't call the fire department until it's too late. Same thing with patient care. So again, that's a very powerful practical strategy and principle. And the failure to communicate, again, requires practice. Let's never lose sight of that, these essential skills that our students must possess. The ACE in Essentials calls them competencies. I love that. We must develop the clinical judgment competencies of problem recognition, priority setting, interprofessional communication, and all that embodies with our students. So again, one of the things that I encourage students to really embrace is that, your provider may not want to hear from you. And that's basically, they got their own stresses, their own calendar, but using the CUS framework, that is an acronym that just is a simple way for a nurse to not lose their bearings when a provider challenges them and kind of minimizes the concern. The nurse has a three-pronged approach that says, I'm concerned is the C. I'm concerned about the patient, and I'm uncomfortable because, and you just simply communicate my concern, my uncomfortableness is related to this data, and this data. And it's a safety issue, the third letter of the CUS, because this is what it could mean. What do you think? And again, bring the doctor, the provider back to that ground zero. But sometimes the provider fails to respond. We don't live in a perfect world. Sometimes we know as nurses, we have a problem. Something ain't right. I can't put my finger on it. And that's why inexperienced nurses don't need to know what the problem is, but they need to know enough to say, I don't like this. I'm noticing something that I'm not comfortable with, like diaphoresis. If you know that means fight or flight, 99 times out of 100, there's a reason they're beating sweat, and it's usually sympathetic nervous system because they're in a crisis. We need to basically either go to the charge nurse, go to another colleague, but we need to basically, again, advocate for the patient and what that looks like. And, when we look at other problems, in practice that we often experience as nurses, we have two other factors that are called acts of omission, what should have been done but was omitted, like I didn't notice this, or I didn't contact the provider, or I didn't communicate the concern clearly. We can strengthen that. Again, practicing these skills. Or acts of commission, which are actually more common, which are things that we do as a nurse. A med error or any error in practice is an example of that. And again, for acts of omission and commission, these are things that, that like with med errors, that's why we have the rights of med administration. That's why we don't compromise the double checks and the triple checks and making sure that everything is in order, because you can make a mistake if you don't do the correct checks. And so again, we have those rights of med administration. But what I added in this chapter that a lot of educators aren't aware of, and I really am excited to have you here with me tonight to talk about this, are the 5 rights of clinical reasoning. And I'm just making practical for students. Again, this book is written, this chapter, as well as this entire book, was written to help students develop the clinical judgment skills. But the bottom line is that these rights, we need to teach them as educators, and this is not typically taught, or it's again, it was an article 12 years ago by Tracy Levitt-Jones that I happened to come across that impacted my journey as a new educator, because I saw the relevance of what Tracy was sharing in this article. And there are 5 rights that we as educators, and really what these 5 rights of clinical reasoning are, they're all about problem recognition of the patient. It's like how can we enhance problem recognition skills? So that's really the title of today's session tonight. This is where I want to drill deep on this, because applying these rights could have saved not only Lewis Blackman, but other patients in practice that unfortunately can, have had adverse outcomes, including death, and it's too late. But these 5 rights are really simple. It's the right patient, the right cues, the right time, the right action, and the right reason. And we're going to break these down right now. And this is kind of where I go into these aspects, and I kind of highlight with key takeaways. And I want you to notice that I always have a lot of reflections, a lot of icons for students to reflect on. So really the key takeaway for students, I say the 5 rights of clinical reasoning are just as important to safe patient care as the rights of medication administration that most students are familiar with or new nurses. So I really want to help them take this knowledge and apply it. But educators, we need to be aware of this. And so again, that poster link that I sent you, that article of the 5 rights of clinical reasoning, you can find the abstract and you can download that article on your database. And so I commend it to you as your next step to strengthen clinical education and problem recognition in your program. But here's where we begin. The 5 rights begins with the right patient. If we want to enhance problem recognition, we need to recognize that not all patients are at an equal risk of developing a complication. Lewis Blackman, for example, was not a high-risk patient. He was a healthy adolescent. But the majority of our patients in the complexity of acute care and other settings, they're at risk. They're on prednisone. They're immunosuppressed. They have cancer. They are on chemotherapy. They've got comorbidities that make them a higher risk. Their very age, if you're elderly, if you're an older adult, you are at a higher risk of developing adverse complications because your immune response is not as robust. Again, recognizing that, is my patient at risk? And if so, why? That's the first step as clinical educators we must do with every student and debrief on this in post-conference. More importantly, do it at the time of care. Don't wait for post-conference. Do it and ask your students, is your patient at risk to develop an adverse event or complication? That is, again, a complication is not the current problem. Complication is what can come out of the weeds, what can develop as a result. Like, for example, any patient who's had surgery is at risk for sepsis and septic shock. They're also at risk for DVTs and pulmonary emboli because of immobility if they're not moving or other contributing factors. So again, right patient. Second right we need to emphasize are the right cues. Now, the right cues is early recognition of clinical data. That's a problem. That's why what I talked about in our last Facebook Live 2 weeks ago, I talked about a simple question that I used in practice with my students and my own reflection on practices. I asked myself, what is the most likely or worst possible complication that could develop with this patient because of why they're in the hospital setting? So for example, again, as post-op patients, always at risk for a surgical for sepsis or septic shock. So again, what are the early signs and symptoms, the early cues of sepsis progressing to septic shock? As we know, it's an elevated heart rate is one of the earliest compensatory responses, as well as an elevated respiratory rate. If there's one thing I want you to take away from this time, is that when they've done studies on which vital sign is most vital to detect a trend of a change of status, of any adverse outcome, the earliest vital sign to change, it's not the blood pressure, it's not the temperature, it's not the heart rate, it's the respiratory rate, usually trending upwards. And a respiratory rate of greater than 16 is a potential early red flag. So again, teaching our students, but what vital sign is usually the most inaccurate in the medical record? Respiratory rate, or least documented. And so therefore, we're cutting ourselves off at the knees if we're not waiting 30 seconds or even a full minute to get that respiratory rate. That trend's going to be not documented correctly, and it could be missed. So again, that's another takeaway. But the bottom line is, right patient at risk. Second right is the right early signs of a potential problem. Third right is the right time. And again, early recognition, not waiting until that blood pressure is 70/30. And again, if you recognize it early, you'll catch it in time before the patient has potentially goes beyond the point of no return and it's too late. The fourth right is the right action. How does the nurse respond? See, this is one of the things that our new nurses are struggling with, according to the studies of Kavanaugh in the Cleveland Clinic, is that they're struggling to do the right action. Even though they may notice a problem, they don't know how to respond appropriately. So again, we can help our students develop a plan of care around a potential complication and talk about that with our students. What is the most likely complication that could come out of the weeds with your patient today because of why they're in the hospital or other setting? Identify it, early recognition. What will you do if it responds? It's kind of like developing a plan of care around a problem. See, nurses don't just use NANDA. In fact, they rarely use NANDA, except acute pain, chronic pain, and a few other diagnoses of NANDA. But the most part, it's all about, that response and responding appropriately with just that aspect of just the essence of what that looks like in practice. And finally, the right reason. What's the rationale? That's why we must always be asking our students why in clinical. Be that 2-year-old, because why is the rationale? Why are you developed? Why would you do this? Why would you do this as a response? Is it the right response? Deep in the thinking. So when a student or a nurse in practice knows that their patient is potentially at risk, the right signs, the right cues that they're looking for, early recognition, responding appropriately for the right reason. They know why they're doing what they're doing. That's why we must develop that rationale and the why. They will be able to strengthen their problem recognition skills. And so again, take a look at that article. And what that looks like. And so again, when you look at the rights applied to Lewis Blackman, he wasn't the right patient, but he did develop a problem in those signs of elevated heart rate, diaphoresis. Why is he having a decreased urine output? Again, if the nurse is just applying basic knowledge of perfusion, and if we're teaching that concept well and deeply, they should be able to make a connection to decreasing urine output and all that goes with it. And again, if that nurse had interpreted and clustered the data of hypovolemic shock earlier, before it got to the point where the patient arrested, it could have been saved. And again, the right reason with the response and the right rationale. And, we have something called rapid response teams currently. And this has been around since the Institute of Medicine study at the turn of the 21st century in about 2000 began recognizing that, again, patient outcomes could be impacted positively by rapid response. And I served on the rapid response team as a circulating nurse in the critical care flow pool where I last worked. And I love that role. But it's also something we need to keep in mind, that we need to develop the thinking of our students before they get into that setting so that they're not dependent upon rapid response to do the thinking and problem recognition for them. Because unfortunately, I have seen at least 2 patients die needlessly because the nurse recognized the problem too late and the patient arrested. One of them we couldn't bring back. And again, was a response of a patient who basically coded because it was unrecognized, the internal bleeding again, until it was too late. One of the things that we can do to strengthen problem recognition is just applying simple early recognition systems like the Muse score. There's a modified early warning score that looks at vital signs. Why are vital signs so vital? Because they're vital. And early changes, even for example, according to Muse, which is again is a recognition, it's a wonderful scale that we can at least introduce in a very simple way to our students, but to teach them that, again, a rate over 15 to 20 is a 1. That's a potential problem. But if it's a 2, which is anything over 20, that's a red flag. So again, we can kind of look at what I highlighted in yellow. A 15 to 20 is a potential, but a 21 or greater and over 30 is an extreme red flag that might be too late. And so again, heart rate, again, anything over 100 is a potential problem. If it's over 120 to 130, that's a red flag. So again, it kind of helps us as nurse educators. We can help our students and teach, some of these early recognition vital signs. Again, a temperature over 100.5 is a 1. Anything over 101.5 is a 2. And so kind of what I'm going to close with today is basically kind of using some basic principles of priority setting and perfusion. It's an application activity that I embedded into this chapter, and this is the very close of the chapter. But what I'm doing with this is making visible vital sign changes and how we can help our students kind of put this together. And so, for example, patient 1 is a 52-year-old who is 6 years, this is all in the acute care setting, who is 6 hours post-op with a posterior spinal fusion. She's afebrile. Her heart rate and blood pressure pre-op were 78 a minute, 132/80. But now, since her return to the surgical floor, her heart rate is now from 78 to the low 100s, and the blood pressure is 100/60. And again, look at the trend. Trending clinical data is an interpreting skill of clinical reasoning. That again, we have a potential concern here. What about patient 2? He's a 45-year-old who comes to the ER intoxicated with a large coffee ground emesis. His heart rate is 110. Blood pressure is 80/40. Let's just pause there for a minute. These are all ER patients. And again, are you concerned about Jen? Well, look at what does the coffee ground emesis mean? Why does it look like coffee grounds? They know what a GI bleed looks like when it's digested. That's coffee grounds. Not because he's eating coffee grounds, obviously. Heart rate is too high. It's compensatory. His blood pressure is low. He is in shock. GI bleed. That should be a blinking red light to our students. Third patient. Jabu is a 68-year-old woman who's post-op day 2 with a partial colon removal due to bowel obstruction. Her heart rate and BP pre-op were 90 and 110/82. She spiked a fever to 101.2, and her heart rate is now 105 and her blood pressure is 100/60. Again, in one short scenario, you can basically just kind of get a sense that where's my trend going? My blood pressure, heart rate, temperature's going up. This is also a concerning patient. And finally, Javad, a 68-year-old with a heart failure, has ischemic cardiomyopathy and an ejection fraction of 15%. His heart rate is consistently 90/100 and appears to be resting comfortably. So again, these are 4 patients that our students need to priority set, which is a skill most students struggle with. And so again, which one of these patients should the nurse see first? Well, I'm going to put my money on patient number 2. And again, this would be a great post-conference discussion. This would again be open-ended. Let your students reason through this. We don't need to, kind of let them put their knowledge together. We guide them as clinical educators in post-conference using an activity like this. You could even take the patients in post-conference. Take 4 students that had kind of some interesting patients, let them present it as a simple report, and then let the rest of the group decide who would I see first, second, third, and fourth. Priority set, practice priority setting using scenarios such as what I've developed or using the patients in post-conference. And so again, number 2 is my priority. My close second is patient number 3, Jabu, with that potential sepsis. Heart rate's going up, temperature's up, blood pressure's going down. Got to investigate that. And number 3, again, is this patient who's got an increasing heart rate, softening blood pressure, but not critical. And finally, patient 4 is basically looks like he's doing okay. 15% ejection fraction. We know that's end stage, but there's nothing critical here that I'm concerned about. And so again, just have a little brief explanation there, and I have students apply their knowledge. What did you learn that was new? And what will you apply what you learned to improve problem recognition? So again, this chapter and this whole text really is a great capstone resource helping to develop clinical judgment for your students. And I'm going to stop sharing, but I would love to know what you all took away from what I shared tonight. I would just like to know what questions do you have about developing clinical judgment skills with your students? And again, what I just want to kind of share, one of the things I'll be talking about at the NCSBN conference is a new term called holistic clinical judgment. Now, it's something that I kind of coined out of the applying holistic care as a nurse, which is body, soul, and spirit. We care for all 3. But to develop holistic judgment, we need 3 components. We need first to develop the caring behaviors, because that promotes noticing. That promotes what you notice and interpret will be influenced by how much you care. That's from Tanner's framework. Volume 1 talks about laying the foundation for professional practice, developing professional identity, holistic care, and what that looks like. The second aspect of holistic care, of holistic clinical judgment, is basically the knowledge of the profession. You got to know your pathophysiology. So in volume 2, I focused on developing clinical judgment skills for professional practice. Talk about pathophysiology, applying that to practice. Cardiac output equals stroke volume times heart rate. Have numerous illustrations of essential content of patho, of pharmacology, fluids and electrolytes, practice-based nursing assessment. Really the bread and butter skills. More importantly, the knowledge, the essence of the science of nursing and applied sciences that we must know as nurses to be safe and interpret the data. And so I basically kind of put, there it is. I've got a link to learn more. I also have an excerpt of volume 3 that you can download right now as a resource. And then volume 3 is developing the clinical judgment for practice. This is like the foundation, kind of like I would call this puts it all together, the clinical reasoning skills of Tanner and Next Gen, that noticing skills, interpreting, problem recognition, responding, reflecting, and transitioning to practice are covered. And we'll talk about that in 2 weeks at the next session. But again, those are the books that, and so Julia asked the question, which book? That is in volume 3, Julia. Developing the Clinical Judgment for Professional Practice. And if you're interested, I'll share, if you go to my website, keithrn.com, I basically have got you can purchase it through the store. If you use the coupon code KeithRN10, 10% discount for those that are attending. So thank you. And just want you to know that's a resource available to you. Destiny's got a question. I'm going to pop it on there before I go any further because I want this to be relevant for your needs. And that's why I'm here. And she says this. Hello, Keith. I'm teaching assessment for first level ADN students this upcoming fall. How do you suggest I teach the clinical judgment model? I will educate them about expected and unexpected findings of the body systems. And then she goes on to say, let me find that. I just lost it here. Destiny, where'd you go here? Oh, let's find it. There we go. I couldn't get the whole thing on my screen. So let me just share this. I'll just read it. Should I teach them noticing cues only or the full clinical judgment model? I don't want to overwhelm them. Destiny, that is a wonderful question, and I've got an answer for you. When it comes to the clinical reasoning steps of Tanner's framework of noticing is a fundamental skill, Destiny. So, for example, it doesn't take a lot of brilliance and a lot of knowledge to recognize or notice that temperature is 103. That's too high. Or that blood pressure is too low. Or why is my heart rate over 100? And so again, noticing is really, in essence, a fundamental skill of clinical reasoning. It's the first step. So that first step, Destiny, is fundamental and foundational. And so this is what we need to do, Destiny. And I encourage you to do this with your assessment, is that your students as novice nurses see assessment as a skill, as a task. What we want to do, Destiny, is teach them concise head-to-toe assessment. But then we basically then say, by the way, when you're doing those breath sounds and you're doing that full head-to-toe, you need to then keep in the back of your mind, what are you noticing that is most important? What are you noticing that might be unexpected? Or what are you noticing that is concerning? Any of those questions, Destiny, unpackage noticing. And so we make noticing a question and we integrate that question with our assessment teaching. I commend that. And that's what we must do to integrate Tanner's framework, which again, the NCSBN model says recognize cues, in essence, the same thing. So again, we're teaching those skills of noticing from day one. And I commend that to you. But then, Destiny, remember this. Interpreting, the next step, is a more advanced skill because interpreting requires you to understand the meaning of the temperature. Why is the temperature high? They need a knowledge base that your novice first semester students don't have. They don't have any clinical experience and their knowledge is infantile, or they haven't had the class yet. So again, we can't expect them to interpret first semester. No, but expect them to notice and then lead them to what it means. And then interpreting skills, the planning, responding skills come in semester 2. Again, nursing process talks about planning at the very beginning, but again, what that looks like. And so just recognize that those skills, again, are basically need to be practiced, need to be developed. And so again, we got to level it like the curriculum. We can't give an infant meat, but we give them appropriate at that age of development. And so give them noticing, Destiny, and then build on it from there. And Lisa asked, where can I buy the books? I just put that in the chat there, Lisa, so you can see the link. They had the coupon code there. And I commend you as educators to check it out. I think that if you're looking to say, how can I really make this thinking practical and practice-based? Because again, we don't want to be just teaching 6 questions and NGN case studies. We've got to make them see how it's related to practice and what that looks like. And so, Destiny, I hope you found that helpful. And thank you for asking that really important question and what that looks like. And so I just look at some of these other questions about, being a lifeguard and familiar with the story. And while you worked at the facility, Chris, wow, that's I'm sure it's the effect there is lingering. I'd love to learn more about just how the cultures change, because that's just a real tragedy. Even that link that I shared, the mother shares her story. Your students need to hear that in a good way, to really sober them, to remember that nursing is not about them. And this mother's tragedy, the worst thing that could happen to a mother, a needless death of her son. It's like that touches my heart. I hope it touches yours, and how we as educators can be a part of the change. That's what this has been about today. So again, I hope that you're empowered to put this together and what that looks like. And so let me just look at some of the other questions here. Start the language from day one and build all the way through until graduation. So yeah, Robin, you're spot on that we use the word noticing. We use the word interpreting. What does it mean? Tanner's framework was derived from practice, and it speaks the language of practice. The Next Gen framework is a measurement model to test students, not to inform practice. So don't use that as a practice-based framework. You immerse yourself and understand Tanner's framework. And one of the things that I didn't do at the very beginning, which I normally do, is Tanner's framework. I happen to have the PDF link. If you are not familiar with her article, Thinking Like a Nurse, published in 2006 that the NCSBN borrowed, lifted literally Tanner's framework of 4 processes that were practice-based, made a 6-step evaluation model, and all the rest of the aspects of the NCSBN borrowed from other frameworks. But again, that is foundational. So I commend Tanner. I want 2 articles for you guys to be looking at before we come back again. Tanner's framework and the 5 Rights of Clinical Reasoning. And if you found this book as a helpful resource, it could help you. It'll help you, I know, as an educator. But again, consider it for your students as well. And so excellent feedback. And let me just kind of say, we have this question from Lisa. Would I get students to understand the importance of the role by using STORE, like the case you discussed tonight? I'm not quite sure the importance of the role by using STORE. That doesn't make sense to me, Lisa. If you want to clarify that, I'd love to answer that question for you. But just in closing here, as we're kind of running out of time, I do want you to know that if you are even remotely interested in saying, Keith, that book looks really interesting, and you'd like to consider it as a resource for adoption, I want to just give you a link that you can go to that would just basically provide you with just a no obligation quote. And again, I'm not here to sell my books. I'm really here to empower you as educators, but I have some helpful resources I just want to share with you. And again, if you found it helpful, you can put that together. Let me just, she said stories. Okay. Would I get students to understand the importance of the role by using stories like the case you discussed? Absolutely, Lisa. You have your stories, Lisa, as well. Every one of us as nurses and nurse educators, we have our stories. They'll forget your content, your students. They won't forget your stories. Bring your stories to your clinical, to classroom, how a nurse makes a difference, how a nurse can actually sometimes even harm a patient like Lewis Blackman. That's a tragedy. We can all learn from it. So yes, they need that. And so you've got a situation here, Destiny. I'm so sorry to hear that your daughter had bacterial meningitis, lost her hearing. Nurses failed to recognize the unexpected findings, Destiny. I can't put your whole thing out there, but I think that educators need to see what you shared. And I'm so sorry. This is what it's all about, educators. It's about patience. Human beings created in the image of God, infinite value and worth, whose life matters just like yours. And sometimes they end or have adverse outcomes, like with Destiny's. She has a hearing loss of some level for the rest of her life. That's could have been avoided possibly. And I guess that's really what's really what we want to kind of just again reflect on. And so again, Destiny, you bring that story, and yeah, bring it back to patient outcomes. We've got to bring it back to the patients. Our students just see themselves, and we've got to help them see it's not about them in a positive way. It's about the patients. So again, Chris, I'm glad you found this helpful. And yeah, Chris says, I'm so sorry. Tragic story, but thank you for sharing. And life is precious. And, that's, as we look at just, this is where nurses make a difference. Nursing has taken some hard hits, the pandemic, just the fallout. It's not easy being a nurse right now, but yet this is where nurses make a difference. And I think we need to keep this before that, you can be that nurse that does notice something before it progresses. And I know that I've been blessed as a nurse in ICU and ER by anticipatory thinking. I've recognized those problems before it's too late. And so again, just want to commend those articles to you. I just want to share in closing that if you're looking for clinical resources to help develop the clinical judgment skills, I've got one resource I just want to share with you. It's my all-inclusive membership called Think Like a Nurse. I have 110 unfolding case studies, different levels of complexity. My case studies are nothing out there, are like nothing in the marketplace. They're open-ended, using Tanner's framework. I wrote them several years ago before Tanner and the next gen was even on the horizon, because I saw the value of using Tanner's framework. And so again, I have tools, case studies, webinar teaching, departmental access at a discount. Individuals can access it right now. You just, and again, just want to commend that to you as a resource, again, that can help develop the thinking that our students need for safe practice. And so again, I just got some closing comments, and then we're going to wrap it up. And so I've got one person who said, I'm a current LVN student. Ms. Hernandez, thank you for joining tonight. Any book recommendations for training? Well, this book that I've been sharing tonight, that you have the links in the chat, this is for students. This is for you, Ms. Hernandez. And I just want you to know that it's there. And so go to keithrn.com and you'll see it on the homepage as a resource for you. And Robin, thank you for your kind words. It's a blessing to serve. That's my pleasure. And it's a blessing to just come to you and share this tonight. So thank you. And Diane says this: we need to revamp our faculty workload, onboarding, continuing ed mentorship, support, evaluation to see if instructors are on the same page. And again, we need to work together to make a difference. And so again, thank you for all that you're doing. And just even educators saying, I can vouch for the Keith Urban membership. So Chris, thank you so much. You've been a blessing on my journey, and thank you for all that you're doing to make a difference. And Lori says this, we use them in our program all the time and love them. And it's really kind of cool, Lori, is that students actually who resist active learning, I get the best feedback from faculty who say that our students were really engaged, because, my cases didn't just come out of the ivory tower. They came out of my lens of current practice. And so I took my scenarios, my stories, made them HIPAA compliant, of course, but really they come from the crucible of real world practice, using Tanner's framework, practicing clinical judgment. And again, I think that can make a difference, and look forward and thank you for all that you're doing. It's been a pleasure to come to you tonight, and thank you for your time and attention. Again, in 2 weeks, I'll be coming at you, and 2 weeks next Thursday, 2 weeks from today, and we'll be talking about transitioning to practice. How can we help our students, again, look at how do you priority set with 5-6 patients? How do you manage time as a new nurse in transition? And so I just want you to know we'll be talking about pearls of practice to transition to clinical practice. And I just want to close that if you have questions, if you have that proverbial splinter in your brain that you need help removing or would like someone to talk to, give me an email. Contact me at keithrn.com. I'm available to any educator who has a question or a concern or a challenge. I will do all I can to serve your needs. And so again, thank you for all that you're doing to make a difference. It's a blessing to provide you with the resources. As you're on the front lines taking the hits, I'm providing you the best possible tools to develop clinical judgment, kind of like Chick-fil-A. They do chicken well. I do clinical judgment. That's really my focus, and strengthening that for nurse educators. So blessings to your day. Have a great summer. Make the most of what's left. And again, let's start strong. And let's not fear next gen. Let's just begin to develop these foundational clinical reasoning skills of Tanner's framework, nursing process. And I'm going to share some powerful strategies in my classroom presentation at the NCSBN conference next month. So be sure to check that out. And I hope to connect with you then. Blessings and Godspeed. Take care.